Good morning. My name is Eva Frazer, and I'll be your moderator for this session on violence and its impact on health. Each of our panelists will give a 10-minute presentation that will be followed by questions and answers. I'm an internist who practices in St. Louis, Missouri. I'm not an expert as our panelists are. But I am a clinician discovering, like many of you, how I can advocate and best treat those who are afflicted by violence. Violence is an epidemic in our society, and it's not limited to the well-known crime-riddled streets of low-income neighborhoods. It can touch any one of us and any one of our patients at any time. A 9-year-old child is not safe doing her homework in the sanctity of her mother's bedroom from a bullet shot from outside the home, ending her life, as happened to Jamela Bolden, highlighting the ongoing tragedy of gun violence. Our college campuses are not safe havens from violence. The film, The Hunting Ground, documents the current prevalence of campus rape. But the impact of violence is not limited to those assaulted or killed in an act of violence. Violence leaves its ugly and debilitating mark on the friends, the families, and the communities of those who were perpetrated. We as physicians are called to serve and provide care for any and all who are in need. It is our duty not only to treat, but to prevent by any means possible whatever ails those we serve. Today we have assembled a panel to address these issues and help physicians better understand violence and its impact on health. Our panelists include Dr. Annelle Primm, a community psychiatrist who currently serves as senior psychiatrist advisor at Urban Behavioral Associates in Baltimore. Dr. Primm was formerly deputy medical director and director of Division of Diversity and Health Equity at the American Psychiatric Association. Throughout her career, her work has been centered on the improvement of mental health care and the elimination of mental health disparities among diverse and underserved populations. We are also joined, next to Dr. Primm, by Dr. Heather DeVore, an emergency medicine physician at MedStar Washington Hospital Center and an assistant professor in the Department of Emergency Medicine at the George Washington University School of Medicine. She is also the director of the DC Forensic Nurse Examiner Program. Dr. Stephen Weinberger became executive vice president and CEO of the American College of Physicians in 2010. During his tenure, the ACP undertook an evidence-based study of the literature on firearm violence, which led to the groundbreaking joint position paper with over 50 physician organizations and the American Bar Association. His efforts have quite literally put him in the line of fire of the NRA. Dr. Jan Gorniak was elected to the position of Franklin County Coroner, Columbus, Ohio, being the county's first full-time forensic pathologist coroner. In October 2014, she became Deputy Chief Medical Examiner of Washington, D.C. Dr. Gorniak advocates for measures to address teen suicide, heroin abuse, and infant mortality. One of my most memorable patients was a woman whose two daughters had been brutally raped and murdered. She first came to my practice several years after this tragedy occurred in her life. With each office visit, she carried with her the horrendous burden of her loss and grief. She was anxious and often tearful, but she was also hypertensive and overweight, and I have to believe that this tragedy in her life gave a great impact on her own overall health. Dr. Primm will be our first presenter and will discuss violence and its impact on health, highlighting the impact of violence on psychological health of your patients and the impact it has on overall health. Dr. Primm.
Good morning, everyone. And thank you, Dr. Frazer, for the introduction. My pleasure to speak with you about the issue of understanding the effects of violence on health and mental health. And I have no disclosures to report. In my outline, I'll be going over violence as a traumatic event, some of the epidemiology associated with it, trauma symptoms, some of the effects of traumatic stress, a bit about domestic violence, and the fact that violence can be multi-generational in its impact, and hopefully leaving you with some points about what you can do as clinicians. This slide shows several types of traumatic events, and the ones that I'll be focusing on are on the left side of the slide: child abuse, family violence, criminal violence, sexual assault. But as you can see, these are situated in a larger group of traumatic events that can have an impact on individuals, families, and communities. The impact of violence on children is significant when we think about this from a global standpoint, with 1 billion children, that's billion with a B, ages 2 to 17, experiencing violence in the past year. And important to think about this in the context of the social determinants of health and mental health. This is a list of the 9 components of that, but I would call your attention to the second bullet, adverse early life experiences. And we know that children and youth who experience adverse events such as violence over time have a significant impact on their health and mental health as they become adults, and even shorten lifespans as a result of these adverse early life experiences, of which violence is a significant component. A little bit about the prevalence of trauma. 90% of people in the public mental health system have had multiple experiences of trauma. When we look at those with a serious mental illness, between 30 to 43% have had post-traumatic stress disorder, and up to 2/3 of people with substance use disorders report childhood abuse and neglect. And so many of the people that we see in our offices and hospitals, some of what the pathology that they present with is associated with some of the traumatic experiences and abuse that they have undergone. 7.7 million adults, which is about 3.5% of adult Americans, develop post-traumatic stress disorder each year. So this is a common problem. Here are some of the symptoms that people with post-traumatic stress disorders and victims of violence may experience. Avoidance is a huge issue, avoidance of trauma reminders, and flashbacks are quite common. The re-experience of the trauma is significantly disabling. Many individuals experience dissociation, numbness, some experience depression and anxiety, and it's not uncommon for people who have been victims of violence to engage in unsafe behaviors and have difficulty with impulse control. Other trauma symptoms include difficulty with sleep, extreme hyperarousal and hypervigilance, and this is often triggered by certain trauma cues in one's environment. Physical tension is common, headaches, body aches, fatigue, stomach aches, and also there can be changes in both adrenal functioning and immune functioning. Other effects of traumatic stress include people feeling very uncertain about their environment, often feeling socially isolated, having difficulty with relationships. Many people have difficulty with movement and sensation, and may be very hypersensitive to pain, or may even have insensitivity to pain, kind of related to that numbness point I made earlier. And then many have unexplained physical symptoms and medical problems. Other aspects that can add to the debilitation of traumatic stress: difficulty managing emotions, having mood swings, and trouble describing what people are experiencing, and being detached, having a sense of depersonalization or spacing out, not remembering things that happened. And as you can imagine, people presenting with these sorts of symptoms, that we might be on our way to misdiagnosing them with other sorts of problems because of our lack of understanding what the genesis of these symptoms are. Self-destructive behavior, being aggressive, having difficulty completing tasks, executive function is often impaired as a result of traumatic stress, and even how people feel about themselves: low self-esteem, shame, or guilt associated with being a victim of violence, and even disturbed body image. When we look at intimate partner violence in particular, as you can see, these three columns point to physical ailments, mental health effects, and social disruption, some of which I've mentioned already. But below the top caption, I want to emphasize the fact that being a victim of intimate partner violence is a significant risk for acute and chronic disease, and victims of intimate partner violence have much higher use than the general public of doctor visits, pharmacies, surgery, mental health visits, and inpatient hospital stays. And so, as you can imagine, this costs a lot, and if we don't intervene early, often people have very poor outcomes and very high utilization. Violence also has multi-generational effects, and particularly intimate partner violence during pregnancy is an example, wherein you have mother-to-infant bonding failure, which often portends a poor outcome in terms of development for the child. And children are more likely to be sick with illnesses like acute respiratory infection, fever, etc. And many women who have experienced intimate partner violence are very harsh disciplinarians. And so some of you may have heard of the saying, hurt people hurt people. And this is an example of how that can happen and be damaging to children and then repeat itself generation to generation thereafter. What can we do? We can certainly take a trauma-informed care approach, and some of you may have heard this term before. And what this entails is recognizing how our medical settings and practices may be re-traumatizing to individuals. You know, one example of this in psychiatry is the use of seclusion and restraint, which hopefully there's much less of that nowadays. But that certainly can invoke a re-experiencing in someone who has been a victim of violence. Appreciating and recording the person's life history, and it should be a part of our history taking to ask about the person's experience with abuse or being a victim of violence. Understanding what some of the behaviors that the individual may exhibit, such as if they experience rage or hostility, that we not think of that person as a bad person, but understand that rage in the context of a history of being a victim of violence and trauma. Using objective and neutral language, and also minimizing the kind of power dynamics that can be quite common in the medical setting because it can trigger a response from the individual who's experienced violence and trauma in the past.
2 minutes.
And so we should assume everyone that we see has a history of trauma until proven otherwise. Very important to use trauma-informed concepts in all situations in our care, screening routinely, asking the question, and it doesn't have to be complex with a special scale, just asking the question as a part of the history taking you conduct. And when we do that, it signals to the individual that understanding their history of violence and victimization really does matter, and that we really do care. So here are some of the takeaway points. Trauma and violence are pervasive and quite significant in the United States, with high rates of post-traumatic stress disorder. Violence in childhood raises risk for health and mental health problems in adulthood. And there's some evidence that chronic or toxic stress associated with adverse early life experiences can contribute to even genetic changes that can then be transmitted across generations. And then the impact of trauma and violence, as we know, causes extensive physical, emotional, behavioral responses. And we need to understand that other multi-generational aspects of violence and trauma are in parenting, with harsh disciplinary practices that again can generate ongoing trauma in the next generation. And ultimately we should employ universal precautions and screening, which involves taking a trauma-informed approach in the clinical setting. Thank you very much.
Thank you, Dr. Primm. So now we're hearing, and I think you're all aware, that violence is present and often prevalent in our practices. As a medical student and as a resident, I was trained to treat the symptoms of violence or the outcomes, the gunshot wounds, the fractures, the broken bones. But I was not really trained in how to recognize and accurately document violence. Dr. Heather DeVore will speak to us this morning on the importance of providers recognizing and documenting violence in their patient practice. Dr. DeVore.
Thank you, Dr. Primm. That was actually a great segue into what I wanted to speak about. So I'm an emergency medicine physician by trade, and I take care of thousands of patients. I work at MedStar Washington Hospital Center, which is the busiest hospital and busiest emergency department and level 1 trauma center in Washington, D.C. We see a lot of violence. In 1 year, last year, we had 450 patients present to the hospital who had suffered a penetrating injury, gunshot wound or stab wound that was considered life-threatening to the head, neck, torso, abdomen. That's on top of all of the other violence we see. So my learning is very practical and very simple and case-oriented. So I want to take some of the discussion points that Dr. Primm talked about and put it into practical settings, the patients that we see every day. I have no disclosures, no financial relationships. I do want to disclose, I do have some pictures in here and a video of violence, and hopefully that won't be offending to anyone. But I certainly, again, am a visual learner. So the take-home points I'm going to tell you at front. Very easy again. I want you to ask. We need to recognize violence. We need to document the violence. And we need to ultimately care about our patients. So what does that really mean? If you don't ask, your patients are not going to tell you. You need to recognize the violence because it's not always the obvious gunshot wound to the torso. If a minor finding is present, that doesn't mean that minor injury occurred. And if it wasn't documented, it wasn't done. We know that routinely in medicine. And finally, advocate for your patient. So this is my clinical setting. It's obvious when someone comes in with this type of violence, when there's a gunshot wound to the torso, we know what to do. We have specific protocols. The majority of physicians here probably don't have this setting. Their setting is more like this. It's more benign and less easy sometimes to recognize the violence that attaches to a patient as they walk through the door. So ask. So these are all patients that I've taken care of. I was working in the emergency department in the middle of the night. It was about 2 a.m. and a 40-year-old woman came in complaining of chest pain. It was a very benign story. Nothing out of the ordinary. I did my typical workup that I do all of the time. We ended up observing her in the hospital overnight. She got serial cardiac enzymes and some sort of provocative test, some stress test in the morning, got discharged. About 2 weeks later, I saw her again in the middle of the night, about 1 a.m. And I looked up her chart, and she had presented to the emergency department in between those 2 times, again with that same complaint of chest pain. She had been again observed with negative cardiac enzymes and discharged home. So she came in this 3rd time with the exact same story. We see this all of the time. And I paused and I said, you know what, why are you here? And I noticed she had some bags with her. She had kind of a small suitcase. I said, why are you here? Trying to reserve judgment, which is sometimes hard when you're busy and stressed in your clinical environment. I said, why are you back? Tell me what's going on. Tell me really what's going on. We've looked at this. We've looked at your heart. It looks okay. Why are you here? And she told me that she was in a domestic violence relationship and was not safe at home and was scared and kept seeking shelter someplace else. That changed, right? That changed a lot. It wasn't the chest pain she was looking for, but she wasn't going to tell me. And she didn't tell this provider who saw her the 2nd time. And she didn't tell me the 3rd time until I asked and provoked that response from her. 55-year-old male came in with a sprained ankle into our fast track. Seen by my PA, said has a sprained ankle, x-ray's negative, I'm going to discharge home. So I went back into the room and I said, what happened? Well, I was in the hallway and I kind of tripped and fell. That doesn't make any sense. I asked further, and he said, well, he's in a same-sex kind of long-term relationship and with an abusive partner. And there was fighting over custody of their child. And he disclosed kind of this long-standing abuse, mostly verbal, and this time it was physical. Same thing with a 26-year-old woman. I saw this patient with a resident of mine who again presented this benign presentation. She has a wrist sprain, x-rays are negative, I'm going to discharge her home. So I went back into the room, I said, why? This is the theme, right? You have to ask these follow-up why questions. Why? Why did your wrist get sprained? That's a little weird. She goes, well, I was trying to get my wallet back from my friend. Why? What, right? That doesn't make sense. Why? She said, well, it's not really her friend. It was her intimate partner who was, again, in this kind of long-standing domestic violent relationship. That makes a lot more sense, right? We have to ask. A 15-year-old boy presented to the office with wheezing. How often do we see this? Almost, 99% of the time it's going to be reactive airway disease, asthma, viral illness, what have you. And I asked why. I asked the question why. So this, I apologize. I don't know if this will work. Let's see. So this is called the choking game. Has anyone heard of this? This is prevalent everywhere. Military, hazing, teenagers. The audio accompanied with this is laughter, right? So he goes unresponsive. They're laughing. Takes a little bit of time, right? So is he going to tell his mother what happened, why he's wheezing? Is he going to tell you? Or friends, probably not, especially if we don't ask. So recognize, this is a patient that I took care of following strangulation. I feel like even my colleagues in emergency medicine get this wrong. Strangulation seems so violent, right? But if you think about the pressure that it takes to occlude the jugular vein or even the carotid artery, it's not much. It's about 4 pounds per square inch for the jugular vein. Think of if you've ever put in a central line, right, and you have to stop the bleeding. It's not a lot of pressure. It almost never shows on the surface. This is a patient I took care of who had a jugular venous thrombosis following a strangulation by an intimate partner. There are no signs here. There are no signs. Minor findings do not mean minor injuries. She was admitted to the hospital, ended up on a heparin drip and anticoagulation for life. Attempted strangulations, this is a review. In this journal, of 300 patients, 50% have no signs present and 68% with no symptoms. Does that mean that it's minor, that strangulation is minor? Absolutely not, right? We know, again, not only this post-traumatic stress disorder, but it's an anoxic brain injury and everything that goes along with that. But somehow in society, we've normalized this and made it and minimized it. So documentation is really the cornerstone of both modern healthcare as well as forensic medicine. And by forensic medicine, I mean all of this, because no one's documentation is safe once an investigation happens, whether it's malpractice, which is what we always think about, but also what about a criminal investigation, right? The physician is the first detective. We can capture those findings that may not be present later, those bruises that go away, those lacerations that heal. That provides mechanism of injury that can then help an investigation. This is so important for us to document. So this was a story told to me by Assistant Chief of Police in MPD. Currently, we're expanding our forensic response to a patient living. It's kind of hand in hand with the Chief Medical Examiner's office. If someone is, lucky enough to experience violence but survive, they end up at my hospital. Who documents that injuries and those findings when they're at the hospital before they die, right? The chief tells me this story all of the time. And as we've expanded to document both on sexual assault and intimate partner violence and strangulation and now attempted homicides that present to our hospital, he says, we had a serial assailant in D.C. for a while, and he was going around the district bashing people in the head with a hammer. And he responded, the chief responded to the hospital after a patient was brought in who was hit in the head. And they had a suspicion that this patient was one of these victims. And by the time he got to the hospital, this kind of blunt injury that was there looked like this, right? It had been stapled up, cleaned up. The physician did exactly what he was supposed to do to address the wound. So the police got there, the chief got there, and he said, hey, can you tell me about this wound? Tell me, is there any possibility this could have been done by a hammer? And the physician's response was, I don't know. I can't tell you. I'm not qualified to say that. Was it blunt injury? Was it anything? How do I know it wasn't a knife? Could it have been in any stretch of your imagination? I don't know. I'm not going to say. What did you document? It was a 3-centimeter wound. Does that help? No, right? He needed that information. He needed some sort of visual representation, either photograph or some physician to care enough to say, this was blunt injury. And I know that because there's jagged wound edges, there's tissue bridging, there's different depths to this wound. Not, I don't know, can't help you, right? Where's the justice in that? Finally, it leads us to care. Really, I say this time and time again, the truth of any story is in the details. Do we care enough to capture those details so that someone can tell the truth of the story? So this is a case that I was an expert witness in. This was a case in prison where a prisoner had been raped by a fellow inmate. He went to the jail, to the clinic there, and this was the documentation that was done. This physician didn't care, right? Alleged he was subject of sexual assault. How often in any other context do we say, this patient presents with alleged abdominal pain? This patient presents allegedly with a headache, right? That introduced an element of bias. Alert and oriented, we never look, right? WNL. Abdominal, genitalia, within normal limits, we never look. Admitting diagnosis, alleged sexual assault. What did he do for this patient? Motrin. He gave him Motrin and discharged him and told the investigating officers, you know what, I didn't see anything. So it probably didn't happen. This inmate ended up staying about 3 months in solitary confinement and had kind of a prolonged jail sentence because he alleged a false accusation. So again, these are my take-home points that really can be relatable to any practice, whatever you're in. Because again, as Dr. Primm said, this is pervasive through all of our society and all of our patients. You need to ask about violence, because if you don't ask, patients aren't going to tell. Recognize the signs of violence, and they're not always that gunshot wound to the torso. And minor findings don't mean minor injury. Doesn't mean that their life isn't going to be changed and altered for the rest of their life. You need to document that aftermath of violence, because if it wasn't documented, it doesn't exist. And where's the justice in that? Because if you want to advocate for your patient, we want to advocate the truth of what happened, and you can make a certain difference. You can advocate that strangulation isn't minor, that it's not a normal part of an intimate partner relationship, that it shouldn't be, and that violence isn't okay. So, thank you.
Thank you, Dr. DeWolf. Taken from the American College of Physicians Ethics Manual is the quote, "Physicians should help the community and policymakers recognize and address the social and environmental causes of disease, including human rights concerns, discrimination, poverty, and violence." Dr. Weinberger has clearly taken this charge to heart and will now discuss gun violence and the physician role in reducing firearm-related deaths in the United States.
Thank you very much. I'm delighted to be here. This is an area that has been of great importance to us at the American College of Physicians, believing that firearm violence is really a major public health problem. And I did want to take a second to acknowledge Dr. Wayne Riley, who is right there in the middle. Hold your hand up, Wayne. Wayne is our current president at ACP, and I think we've been wonderful partners. I certainly have viewed him as a wonderful partner in working very strongly with all of us to bring this issue to the forefront. So I have no financial disclosures. So I will start by giving a sense of kind of where the problem is right now, and I will close by giving you an idea of what we are doing, certainly at ACP along with other organizations, and what all of us need to be doing as clinicians to address this problem. There are now about 33,000 firearm-related deaths in the United States every year. 33,000. That's almost 100 a day. And interestingly, about 2/3 of those actually are suicides, and about 1/3 are homicides. Obviously, there is a much larger number of firearm-related injuries. The number is about 75,000. Many of those are actually in the younger population. One of the most striking things is looking at what firearm-related violence is in the United States compared with other countries. There is no other country in the world that is anywhere close to the United States in terms of firearm-related deaths. You can see that the next country is about 1/3 of where we are in terms of deaths per 100,000 individuals. Look way over toward the right, the United Kingdom. It's the third over from the right. I don't even know what percentage that is compared to the United States, but it's trivial compared to the United States. So we do know that access to guns increases injury and death. And I'm not going to go through the details of this. Clearly, ownership of a gun has been associated with an increase in the risk for death. Keeping a gun in the home increases the risk for homicide in the home. About 3/4 of homicides in the home are committed by someone who's known to the victim, such as a family member or an intimate acquaintance. This, to me, is one of the most striking things, and I would like to tell this to the people across the hall at CPAC, quite frankly. When they say that guns are needed for self-defense, for every time a gun was legally used in self-defense, there were 11 attempted or completed suicides, 7 criminal assaults or homicides, 4 accidental shootings. Now, where are our priorities? Is it self-defense, or is it the other issues that come up in terms of homicide, suicide, and accidental shootings? What about firearms and suicide? Clearly, access to firearms in the home greatly increases the risk for suicide. And the majority of those suicides are actually impulsive, occurring with less than 24 hours of actually thinking about it. If you look at the data, again, I won't go through the specific data, but the bottom bullet there is suicide rate among the group of people in California who purchased handguns who were over 21 years old. Suicide rate in that group in the first week after purchase was 57 times higher than the general population. This came clear to me when I received an email from one of our members of the American College of Physicians after we had put out a position paper on firearms violence. And many of the emails that I got, or some of the emails that I got, were people who were complaining, people who were from the far right, who were saying that ACP should not take a position in this area. And I was concerned that this email might be along those lines because it was someone from a rather conservative state. However, what he said, and this is a quote, "I have a personal stake in the battle. Since my son was a victim of impulsive suicide with a handgun he purchased just a few hours before he died. like to suggest that you include suicide as a major but often silent component of gun violence. Action should include a waiting period for taking possession of a gun, a requirement for gun safety training, and safe gun storage at the home. Obviously, a very heartfelt plea from him. So it's clear that there is a need for appropriate regulation. States with weak gun laws and higher rates of gun ownership have the highest overall gun death rates. States with the strongest gun laws have the lowest overall gun death rates. We're also dealing with some other issues in society right now, and there are two specific issues I wanted to mention. One is the Dox versus Glocks law in Florida. How many of you are aware of that? Probably about half of you. So that law in Florida prohibits doctors from asking patients about gun ownership or recording information about gun ownership in the medical record. Missouri is trying to follow Florida to some extent. It's also quite restricted, not quite as bad as Florida. So this is an issue where they are talking about this as obviously a Second Amendment right. There is a lawsuit from a number of physician organizations, including the Florida chapter of ACP, that this is a First Amendment violation because it's violating free speech for physicians. Second big issue is funding of firearm-related research. And in 1997, Congress removed what is really a trivial amount of research funding, $2.6 million for firearms research. In 2013, President Obama ordered CDC to resume research, so it is clear that CDC can do that research, but they have $0 in funding, zero. So we've been developing policy at the American College of Physicians about firearms. We first put out a position paper in 1995 talking about firearm violence as a public health problem. We had a follow-up position paper in 2014. And then in 2015, we issued, along with many other organizations, a collaborative call to action paper that involved 7 medical professional associations: internal medicine, pediatrics, family practice, surgery, emergency medicine, psychiatry, and OBGYN. So the national organizations for all of those types of physicians, plus the American Public Health Association and the American Bar Association. And that paper has subsequently been endorsed by 52 organizations, and I'm pleased to say, including the National Medical Association. So the positions in that collaborative call to action paper: universal background checks, elimination of gag laws, restricting manufacture and sale of military-style assault weapons and large-capacity magazines, research to support strategies for reducing firearm-related injuries and death, and improved access to mental health services. The American Bar Association, which had similar policies, said that there was nothing in our recommendations, which are really common sense. They are not radical recommendations. Nothing in those recommendations violates the Second Amendment or previous Supreme Court decisions. ACP's 2014 paper had some additional recommendations, which we did not include in the collaborative call to action paper because some of the other societies did not have these specific recommendations. But we did feel very strongly about the need for waiting periods to reduce impulsive suicides. Guns should be subject to consumer product regulations, and guns should be subject to law enforcement measures to aid in the identification of weapons used in crimes. So what should physicians do? We need to speak out individually about the prevention of firearm-related injuries and deaths. We need to work with other groups. And obviously, we need to build a consensus for social and legislative change. We need to counsel our patients on the risk of firearms in the home. You can do that if you're not in Florida or not in Missouri, but hopefully we will be doing that. We need to become informed about firearm injury prevention. We need to discuss with patients ways to mitigate risks from firearms. And most important, we need to advocate for national, state, and local efforts to enact legislation that will reduce preventable deaths and injury from firearms. I think I went back there. So thank you. Again, I appreciate the opportunity to speak here.
Thank you, Dr. Weinberger. In order to reduce violence, we must as physicians begin to take a systematic approach to violence as a disease. Dr. Jan Gorniak will be our final presenter and will discuss violence as a preventable disease and give insights into how we can reduce violence in our own communities. Dr. Gorniak.
Yes. Good morning still, yes? Good morning. It's kind of ironic that I'm last, right? I'm coming from the medical examiner side, and some people also think that we're the end of the story, and that's where it starts. And sometimes it is, but as a forensic pathologist, I see that as the beginning of the story for my patient. So I get to tell their story, get to give a voice to the voiceless. And in autopsy rooms, some autopsy rooms, there's a Latin phrase, and I don't speak Latin, so I'll translate it to English. It says, "Let conversation cease, let laughter flee. This is the place where death delights in teaching the living." So that's what we do. So autopsies are important because we also sit on a lot of valuable data at the medical examiner's office because we are at time zero. So we know things before you know things. So if you're going to look for statistics or trends from vital statistics, they're a couple of years behind. We know in 90 days whether we've had heroin overdoses or how many people have died from suicides because that doesn't make it on the news. Okay, you know about the homicides that are occurring, but not the suicides. And I agree, we can't forget about self-injury too as violence. So just real quickly, what do we do at the medical examiner's office? We determine cause and manner of death. So what's the cause of death? And then the manner is natural versus non-natural. So violent deaths are what we investigate legally, is what our charge is to do, investigate those non-naturals. So the manner of death is the circumstances that led up to the death. So there's 5 manners: natural, suicide, accidental, homicide, and undetermined. So when we say homicide to the medical examiner, and sometimes it's used interchangeably with murder, that's not what we mean. So homicide is the death at the hands of another. So death at the hands of another, just because you didn't mean to shoot your cousin, doesn't make it an accident. But just because we rule something a homicide doesn't mean someone's going to be charged or not charged. And the same thing with accident. If something's ruled an accident, that doesn't mean someone can't be charged with culpability of that person's death. So when we talk about violent death, a violent death results from the intentional use of physical force or power, threatened or actual, against oneself, another person, or a group or community. So the person using the force need only to have intended to use the force, not intended for the outcome of the use of that force. And that's what I'm saying. We don't get into justifiable death at the hands of another, or we know that someone intended to harm themselves. That's how we determine our manners of death. So we also include, when we talk about violence or against oneself, we can include drugs in that definition also. So when we talk about a public health approach, so the medical examiner's office, we have our public health hat. So what we do can save lives. And that's why it's important to do autopsies. That's why it's important to not only ask those extra questions, because yes, we can have someone who is a hanging or gunshot wound to the head, suicide. That's simple, right? Cause, gunshot wound to the head, manner, suicide. But we ask those questions about stressors. So even though our patients can't respond to us, we do ask that, because that is important for going forward in the prevention of further deaths. And it's also important, I think we're all speaking the same language up here, that the survivors are now at an increased risk for violence. So when we have the public health approach, we define the problem. So this is in general. So how big is the problem? We learn about the problem by gathering and studying data, and then where prevention is most needed. So we get this information, and then we can target where it's needed. Identify risk and protective factors. It's not enough to know that it is affecting a group of people. We also need to know why. And then we can develop programs to reduce or get rid of risk factors and increase protective factors. Develop and test prevention strategies. And then using information gathered in research, we can develop these strategies. And then we want to, sharing is caring. So we want to share the best preventive strategies and to prevent these deaths. So natural diseases, okay? Smoking can lead to cardiovascular disease and death. So how do we prevent it? We try to tell people don't smoke, right? So we start at the prevention. In Ohio, when I was in Ohio, we looked at heroin deaths, and they started at the end. They looked at how many people were dying, and then the one step back from that was, why weren't they in treatment? What's wrong with these treatment centers? You know, rehab didn't work. I wanted to go further back, and why are we prevent the use of the drugs in the first place, right? So why are we taking one step back? So the same thing here. We can tell people to stop smoking, but we need to go further back and not start smoking in the first place. That make sense? Right? Okay, good. So the same thing with violence. We talk about choices, and like when I was introduced about, I like kids. Those kids in this picture depicting that one bad choice from jail or death. Okay, so we have to go back to they're not making those decisions, you know, those consequences of those, and understanding that. So the bottom arrow is showing books to success, education. So statistics show that the higher the graduation rate, the lower the homicide rate. So we put books in children's hands, make them, you know, do well in school, see a different path, make a different choice, then that can also lower the violence that we're seeing. So here's the same public health approach. Okay, so the same thing, we can talk about the cigarettes, we can talk about obesity. Now we can define the problem, identify risk and protective factors, develop and test prevention strategies, and ensure widespread adoption. So the same steps that we use for preventative medicine on natural diseases, we can use in the violence prevention also. Oops, sorry. Okay. So youth violence is widespread in the United States. It's the third leading cause of death for young people between the ages of 15 and 24. In 2012, almost 4,500 young people aged 10 to 24 were victims of homicide. That's an average of 13 a day. So death resulting from youth violence are only part of the problem. Many young people need medical care for violence-related injuries. So they're going to show up in the emergency rooms. They're going to have mental health issues that we have to address. Their family members are going to be victims or potential victims, so we can't forget their mental health also. So there's a number of risk factors that point to youth violence. So there's a history of youth violence, drug, alcohol, or tobacco use, association with delinquent peers. So you've heard, show me your friends, I'll show you your future, right? So that's in there. Poor family functioning, we got to get our families together. Poor grades in school, high the graduation rate, lower the homicide rate, and poverty in the community. So just like my job is multidisciplinary, so besides the forensic pathologists, we have investigators, we have toxicologists, we have morgue staff, we have to have information from the hospitals, we have information from the police. We're all on the same team. We play different positions, but the team needs to play together. So that's how we're also going to do this. It's not just one of us. It's going to be different disciplines, different areas coming together. So it's just not the child. It's just not the person. It's the family. It's the community that we can plug into this public health prevention model and curb some of the violence that's happening. So the ultimate goal is to stop youth violence before it starts. So it's not the one step back from death or jail. It's preventing it from the beginning. So there's several prevention strategies. So developing safe, stable, and nurturing relationships between children and their parents and their caregivers. So there's parenting programs, parent and child programs, support groups, media intervention. I know we don't want our kids being raised by TV, but there's good TV, some good TV. So we have to get the media, get off Facebook and, utilize that in a positive way. Develop life skills in children and adolescents. So it can be academic enrichment programs, Head Start programs, vocational programs for underprivileged children, reducing the availability and harmful use of alcohol or any other drug. And then reducing access to guns and knives. So we're just not talking about guns, we're talking about sharp force injuries as well. Promote gender equality to prevent violence against women. So in our schools, we can have school-based programs can address gender norms and attitudes before they become deeply ingrained in our children. Changing culture and social norms that support violence. Victim identification, care, and support programs. So in the cultural people, we talk about the effects of violence, and we talk about the mental health. I grew up where you don't talk about mental health. You know, it doesn't exist. There's a stigma to it. Same thing when we rule something as suicide. People don't want it to be ruled as suicide. So we have to be willing to talk about it. So this is great that we're here having this conversation. So we can't be ashamed to talk about it. We can't be ashamed to ask those questions, to evoke those answers that we need to keep our people, our communities safe. Sometimes violence is an acceptable way to handle conflict. Remember the days you used to go out and duke it out on the playground, right? That's what you used to say, you know, but that's not where we're going to use our words. We're going to encourage nonviolence, but we have to be able to recognize and step in and prevent. And victim identification, care, and support programs, grief counseling, mental health services are very important. So, once again, we're not the end of the story. We're the beginning of the story, and then we can, don't forget that we can, as the medical examiners, coroners, forensic pathologists, we do have this role. Of course, any day I go to work and I don't have a patient is a good day, okay?
Yes, a round of applause for all of our panelists. Thank you. So now we have time for questions and answers, and I guess I'd like to start with Dr. Weinberger. What kind of support have you received from members of the ACP with your proposed?
Yeah, interestingly, I would say the large majority of our members are very supportive of our taking this role. But as one might expect, we have 143,000 members. It's a very diverse membership. So we do get a certain number of emails and blog posts that will be against what we're doing. And some of them we actually find are, when we look into who has posted those, they're actually not from members, but they're actually from presumably the NRA and their network getting things out there. But by and large, it's been really quite positive.
Thank you. Yes.
Legislation that stopped funding for gun studies. How do we go about lobbying? Who do we talk to try to get that money appropriated to CDC so that we can actually have these studies so that we can understand that gun violence is indeed a public health crisis?
I'll tell you, I wish I had the answer for that. I mean, one of the things we know is that legislators have been so They are so fearful of the NRA and the gun manufacturers and the effects of the lobbying. We know in Colorado that 2 state legislators, when they were trying to get some gun laws passed with a public referendum, they were actually pulled from office, essentially. Quite frankly, I think until we get some change in the representation in Congress, it's going to be hard to do this. President Obama has been a real supporter, and we certainly support the things that he has wanted to do. I think all we can do is to try at the local level to lobby with our legislators and to get the public out there speaking with one voice that is against what's going on right now.
So I see a gentleman has the mic, and then the lady in the red jacket next.
I'm Dr. Weinberger, chaplain for DC Med-Chi. I used to be the medical director for DYRS, incarcerated youth. I thank the panel for an outstanding and comprehensive discussion of a very important subject for those of us in adolescent medicine. I know Dr. Primm mentioned the fact that sleep disorders were really associated with post-traumatic stress. Could you expand on that, Dr. Primm, relative to, I know with my patients with ADHD and ODD, sleep is such a key part. But again, it can either be a causative as well as a symptom of it. Could you expand on that part of it? This could be an area that we could look at in terms of prevention. With my patients, the more I take care of the sleep problems, the better my medicine works for the other problems. Thank you.
Thank you for your question, Dr. Faget. Sleep problems, they come along with, I guess, the kind of irritation that the trauma causes to the system and disrupts the homeostasis in general. And it can be a problem, an isolated problem, and also a problem that's associated with anxiety and depression. And so sometimes treating the anxiety and depression that accompanies the post-traumatic state can be helpful as far as the sleep is concerned. And also, some of the approaches for the treatment of post-traumatic stress disorder that involve mindfulness training and some of the cognitive behavioral approaches, and also exposure therapy that helps to desensitize the person to the trauma that they've experienced, and really create a different mindset around what has happened to the person can kind of help overall with their mental state and also have positive effects on sleep.
Thank you. Yes.
Hi. Virginia Kane, I'm director of the health department in Indianapolis. I'm a bug doctor, and I practice out of the 4th largest public health hospital in the city. And we have such a tremendous amount of violence in Indianapolis. We now you have to go through security like you go through the airport in order to get into our emergency room, because if we have a gang member that's shot, then we have to have sort of like a lockdown, because those are gang members are coming for retaliation. My question is, one, why are we not focusing more on getting more mental health dollars? That's been dropped significantly in our states. I think we should be pushing that. Secondly, so that's for Dr. Weinberger and for Dr. Primm. And Dr. DeVore, do you guys have a violence prevention program? We have something called Prescription for Hope, where if all the people come in for trauma, gunshots or stabs, we try to get at their siblings who are going to be a generational thing, trying to do prevention. Do you have something of that nature?
Well, and maybe we might talk about if someone has some information on the ceasefire program, which really talks about interrupting violence. I don't know, Dr. DeVore, if you have information related to that.
I can tell you what we're doing in D.C. The mayor is very focused on this and has spent considerable amount of time gathering together both community and government agencies to work together to prevent this cycle of violence. There's something that she's promoted called the community stabilization response. And as part of that there's also a crisis continuum response. So when someone comes in who is a victim of attempted homicide or or a homicide, there's a group of kind of agency workers that include mental health professionals, victim advocates, community kind of stabilizers, community youth who respond to that family, looking for that potential for retaliation, looking to help them with other aspects that could potentially propagate that violence. So whether it is, if it creates a homeless situation, if there's money and crime victims compensation, if there's that acute crisis response or psychiatric need, if there's ongoing behavioral or mental health issues that need to be addressed.
Thank you.
And at the ME's office for the survivors, we have grief counselors. So not only for the survivors, but our survivors of our patients, next to kin and family members, there is grief counseling available to them at our office also.
The other part of your question about mental health, I mean, clearly there needs to be more mental health services available and more funding, and President Obama certainly called attention to that after Sandy Hook with a greater focus on mental health. At the state level, that's with the legislatures. They need to understand that, being penny wise is being pound foolish, because when mental health is not sufficiently funded, then there are other social costs, higher utilization for other health problems, higher incarceration rate, and so forth. And so clearly, it's a good investment, and more needs to be done.
Anyone else? Another question? Okay. Well, we got the close order. I'm so sorry. Are the panelists going to be around for a few minutes? Okay, maybe afterwards. Sorry, we have to end.
Thank you.